We're actually delighted to have Dr. David Eschelman and Dr. Takami Sato here. I'm going to thank you all for your flexibility to do it a little bit earlier. We have a train to catch, so we'll be sure and pepper him with as many questions as we possibly can before he rushes out to get a cab at 6:20. But by way of introduction, David Eschelman is an Associate Professor of Radiology at Jefferson Medical College, an Associate Director of Interventional Radiology at Thomas Jefferson University in Philadelphia. He is board certified by the American Board of Radiology with a certificate of added qualifications in vascular and interventional radiology. He currently focuses on liver-directed therapies for patients with metastatic working closely with Dr. Sato and Carin Gonsalves, MD. Dr. Sato, who is fresh from the other side of the globe in Japan, so pardon the jet lag, is Professor of Medical Oncology at Jefferson Medical College of Thomas Jefferson University, and at Thomas Jefferson University Hospitals in Philadelphia as well. Currently, he serves as the Director of the Metastatic uveal Melanoma Program in the Department of Medical Oncology at Thomas Jefferson University Hospitals, and is co-leader of the Immunology Program at the Kimmel Center at Jefferson, and is the Associate Director for International Affairs at the Kimmel Cancer Center at Jefferson. So join me in welcoming the doctor.
Thank you very much, everyone. We want to start out by thanking Grant and his other family members and everyone else who works for OMF for getting this whole thing organized and bringing us all together here, because we can certainly tell that there's substantial interest in this program by evidence of the registration, and not only an opportunity for everyone to learn a lot, hopefully, but obviously a lot of social events and interactions planned too. Also, thank you to Grant for accommodating my schedule. There's something my wife and I had planned to do with our two little kids tomorrow, so hence I'll be leaving as soon as we're done. As Grant and I corresponded back and forth about what this session tonight should be, I kind of suggested an old-style seminar setting. Rather than having Takami and me just stand up here and lecture to you and go on and on with lots of slides and that sort of thing, we kind of thought, let's make this interactive. Let's talk. We can be a little casual. I mean, Takami and I are friendly, we're approachable, and so what I have is about a less than 10-minute introduction on just some background information and that sort of thing, and then we'll be happy to take questions from the audience. Recognize, even though we're here in Washington, there's no teleprompter here, so not sure what you're going to get, but that is, the goal of this session. And also, I do have a number of images if you want to talk about different therapies and what it looks like on those MRIs and arteriograms. I did bring a number of those things too. Recognize that of the group who takes care of metastatic uveal melanoma patients at Jefferson, Takami's the brains of the operation, and there's no question about that. Carin and I are the compassionate plumbers of the group, but there are going to be...
Who's great?
That's kind. But I mean, clearly it will be obvious where some of these questions will be directed. So, based on that, let me just... Okay. I'll be discussing unapproved uses of commercial products. And I'm glad you asked, because I was planning on explaining it. For example, say Merck produces a great drug to treat high blood pressure, and they get it approved by the FDA, and then lots of people start taking this drug, and lots more people start taking a drug, and then people start realizing, out of the blue, no one taking this drug gets colon cancer. I'm making this up, okay? And then people do studies and say, wow, everyone on this high blood pressure drug doesn't get colon cancer. That's great. They publish papers about it. Merck can't go and sell this drug or even mention the fact that no one gets colon cancer on this drug unless they go and do a big study and have FDA approval to market it as, hey, this doesn't kill no one gets colon cancer. Doctors have the total right and every day use medications, devices, all these things in an off-label application, meaning the FDA approved it for one thing, we know it works for 10 others, and doctors are allowed to use it for the 10 other things. So I'm glad you asked, because I thought that was a worthwhile explanation.
It was a very good explanation, except when the drug that it was first used for, they discovered that it doesn't actually perform that function.
That's a different situation.
And that's a different lecture.
That's a different lecture. This is just the fact that many of the things that interventional radiologists do and use are off-label uses. And I am a consultant for Lapie et al. In trying to get a different indication here in the United States. Another basic thing. So what the hell is an interventional radiologist? Okay. Interventional radiology is a subspecialty of diagnostic radiology. What is diagnostic radiology? Diagnostic radiologists are the physicians who interpret CAT scans and ultrasounds and MRIs and chest x-rays and barium enemas and all that sort of thing. Training for a diagnostic radiologist is a year of internship in something, 4 years of radiology, and then most radiologists do 1 or 2 years of fellowship in addition beyond that. Interventional radiology is one of those subsets of diagnostic radiology. We do surgical type procedures under imaging guidance, usually x-ray guidance, sometimes ultrasound, sometimes CAT scan, through tiny incisions. And my training was a year of surgery, 4 years of radiology, and then 2 years of interventional radiology, so 7 years after medical school to become an interventional radiologist. The goal of this evening is not to be an advertisement for Jefferson. That's not why Takami and I are here. However, I briefly want to just add some perspective of why the two of us are here, and then we'll go on with the rest of the talk. We are a national referral center for patients with metastatic uveal melanoma, as many in the audience are aware. Not only national, we are seeing patients from Canada and some other countries around the globe. 3/4 of our patients live outside of Pennsylvania, New Jersey, and Delaware. We're located in Philadelphia. Those 3 states are considered our local area. Anyone outside of that is traveling in. We have a weekly multidisciplinary conference dedicated to metastatic uveal melanoma, coordinated by Renee Zielinski, who's sitting over there. It's Takami, 2 interventional radiologists, a body MRI specialist, oftentimes a radiation oncologist is there. We have a weekly metastatic uveal melanoma multidisciplinary clinic where we see only patients with this very, very rare and very aggressive disease. We're performing about 400 liver embolization procedures a year at Jefferson, and just part of this is Jefferson has a long-standing active melanoma program, and we're affiliated with Wills Eye Hospital, which is a block down the street, and they see about 1/4 of the patients in this country for the primary tumors. It's not fair to discuss our program at Jefferson without also mentioning Carin Gonsalves, who's back keeping the home fires burning and is on call tonight. We received certificates of appreciation from this organization a couple years ago. To go through some background information. Okay, I'll show a picture in a moment of the uveal tract, but it consists of the iris, the ciliary body, and the choroid. Uveal melanoma is the most common primary tumor of the eye in adults. The incidence is less than 1 in 100,000 people per year in this country. There are about 2,500 new diagnoses per year in this country, and most patients have known tumor limited to the eye at the time of their diagnosis. Mean age is in the range of 50 to 60, incidence peaks at age 70. 98% are Caucasian, based on a paper I read on the train coming down here this afternoon. Just I'll look at the statistics from last year. It's usually not hereditary, although we had a speaker at our institution this week who's doing some tremendous genetic research on this rare disease, and he points out that in a couple % of patients there are some associations with other tumors and other sites. The incidence is not increasing, and the incidence has been flat over at least the past 36 years in this country, based on that same article I read on the train coming down. Probably not a linkage to ultraviolet or sun exposure, as opposed to skin melanoma, which is clearly related to sun exposure. Some weak linkages to skin melanoma. Okay, so the iris is the colored part of our eye. The least common site and best prognosis. They tend to grow slowly, and they're usually detected pretty early because you can see that site.
Excuse me, can you take down that the board?
Okay.
The patients on this side of the room can't see.
You know what? I have an idea.
Let's fold it up.
Well, see, the thought is that when it gets, you know what? I'm going to bring it back like Renee. No problem.
Sorry.
Thank you.
Sorry, Dr. Oshman.
Don't apologize. I'm quite used to her telling me what to do.
Sorry. We just can't see. We don't have a view of it.
Yeah, it's okay. Okay, sorry.
Thank you.
I suspect we may be using that later for question time. That's why Grant kindly got it here. Okay. The ciliary. Whoops, sorry. The ciliary body is this little muscle thing which causes accommodation, making the lens bend so we can see distances and that sort of thing. Uncommon, and it has the worst prognosis because it tends to expand outside of the eye. The large majority of these are the choroid, which is this little yellow band. Diagnosis is by looking in the eye, ophthalmologic exam. They use ultrasound, fluorescein angios, where they inject this stuff and they can see the blood vessels in the tumor. Most common symptoms are none, and vary things like blurred vision or floaters and flashes, field defects, rarely painful. Okay, what am I doing? There we go. Sorry about that. What are potential treatments for the primary tumor? Again, this is when it's still just localized in the eye. Well, in patients who are very old or in very poor health, some may opt for just observation and no other treatment. TTT, or transpupillary thermotherapy, kind of like a laser, is good for treating some small sites, probably not great as a primary therapy due to a high failure rate. Many in the audience are familiar with plaque radiotherapy. Sewing a little disc onto the eyeball at the site of the tumor. It's the most common therapy in this country right now for the primary eye tumor. The 10-year local recurrence rate is very low. It does a good job at controlling the primary tumor. External beam therapy, radiation therapy externally coming into the to treat the primary tumor. Local resection, pretty uncommon for some rare anterior tumors. Enucleation, taking the eyeball out, used for large tumors, anterior chamber tumors, those that recur, etc. I'm sorry, sir?
The 3.5 recurrent.
Yeah.
What is that?
Okay. If radioactive plaque is used to treat the tumor in the eye, how often does a tumor show back up again in the eye? And according to that study, 3.5% of the time.
And
I'm sorry, yes?
timing, how long does, in your average estimation, would that take for?
I'm going to give you an honest answer.
I'm
not the ophthalmologist, and I don't know. Do you know, Takami?
Take-home message is local recurrence is extremely rare.
It's what?
Local recurrence is extremely rare.
Rare.
And
I like that.
Yeah, usually I would say maybe a couple years to 5 years range. Sometimes patients start having a regrowth of the cancer, start having more pain or some visual problem. But most of the case, once you have a local eye treatment, it is cured in general.
These are approximate survivals from diagnosis of the primary tumor. 5 years, about 70%, 10 years, about 60%. And almost half of patients with diagnosis of the primary tumor in the eye will develop metastases. Yes, sir? All comers.
You might want to repeat the question.
Sorry, the question was, those rates are with which treatment of the primary tumor, and that's general for all comers, because there's not a known survival with either plaque or enucleation. But to the best of my knowledge, there's not a distinguishing of survival benefit of one over the other for most tumors. With larger tumors, enucleation has a survival benefit. But I'm going to show something in a moment which will come back to that question. There's an oft-quoted article, importantly from 20 years ago, out of Mass General, of the median survival after development of metastases is dismal, 2 months without treatment, up to 5 months with some form of treatment. Obviously, this has been changed over the past 20 years.
Thank God. Yes.
I agree.
Yeah.
Okay, so why are we focusing on the liver as regarding metastatic disease? That's because the liver is the predominant organ of involvement in more than 90% of patients with metastases. It tends to be the first manifestation of the disease. In half of patients, it's the only manifestation of the disease. If a couple people want to sit on the floor around here, I mean, it won't bother me at all, as long as you don't block the projector.
I have a question. Are you going to have a handout with all this nice stuff on it? Please.
That would have required thought and planning and a big box brought down on the train. But, let me do this. After the meeting, I'll contact Grant, and we'll figure out something.
And you'll have him do it. Okay.
No. We'll figure out something. Okay? We'll figure out something.
Thank you.
Yeah.
Okay.
You'll have a hardbound copy sent to you.
This is quickly going to lead to a level of IT sophistication that vastly exceeds my abilities. Hey, I'm lucky I know how to make slides and put pictures on them. Okay, so anyway, that's why the liver's important here. Okay, other sites of metastases include the lungs, bone, brain, subcutaneous tissues, other organs in the belly, or the tissues around that. And here's the other important point. The clinical course of patients with metastases is generally determined by the progression in the liver, or therefore by the control of the disease in the liver. And the pattern of metastases is very, very different from patients with skin melanoma. Skin melanoma tends to go locally to lymph nodes, the lung, spread subcutaneously. Okay. Risk factors for metastasis once you've had the primary tumor in the eye. Older patients, men, as logic would suspect, bigger tumors. If they're bigger in diameter, thicker, more prone to metastasis. Tumors that are located more in the front of the eye. I'm not a pathologist, but looking at the types of the cells that make up the tumor, epithelioid cells are worse than spindle cells. If they have a lot of lymphocytes, which is another type of blood cell infiltrating it, and some other factors, again, which are all pathologically based. What's the estimated time to metastases? Well, if you're sort of the worst case situation, which is an older man with a big tumor, the median time to survival is median time to metastasis is 20 months. And just, you're going to hear the term median here a lot today. What's a median? It's actually not the mean is the average. Median is if you have a group of 20 patients and some live 6 months and some live 12 months and some live 15 months and some live 20 months and some live 5 years, how long did the middle person live? Median is that middle individual.
The point above which and below which half of the cases fall.
Yes. And that's a more intelligent way of saying it.
That comes from a math teacher, obviously.
Okay,
No,
thank you.
sociologist.
I'm sorry?
She said I was a
Oh, sociologist. Okay. Okay, so better characteristics. A younger woman with a small tumor. The time to metastasis on median is over 6 years. Okay? And here listed are 5-year mortalities based on size of the primary tumor. And again, please understand, we're here to talk. I'm not here to try to depress people or anything like that, but everyone who's here knows we're talking about a very aggressive, nasty disease and what we can do about it. Even though there's better treatment for the primary tumor, particularly with the development of the radioactive plaque, it hasn't changed survival. And there are, most likely that's because there have been tiny tumor cells which have spread throughout the body prior even to diagnosis of the tumor in the eye. There's a lot of work being done on the genetics of these tumors. And again, I'm not the geneticist here, but we can go through a few of them. Everyone in this room has 46 chromosomes, which means you get 23 of them from mom and 23 of them from dad, and they go together. So we have 46. But when the tumors start growing in the eye, some of them in the process of becoming tumors and developing lose all or part of one of their number 3 chromosomes. That's called monosomy 3. And patients with monosomy 3 have a much higher rate of metastasis and subsequently death. And again, we had this really great speaker this week, and I'll get to that question in just one second. And he explained that the reason is there's a gene on the 3rd chromosome. And if you have both of the genes on each chromosome, that tends to suppress tumor, both tumor in the eye and metastases. But if you have monosomy 3, meaning you only have one of those number 3 chromosomes, you therefore don't have a pair of these genes, and therefore you lose that tumor suppressor effect, was his explanation. Okay? In patients who have both number 3 chromosomes, some patients have duplication of part of the number 8 chromosome, which tends to fare a little worse. Some people have a little extra on the 6th chromosome, which actually has some kind of protective effect. And then there are also some other changes in the number 1 chromosome. one of the other interesting things is, and how do you learn this stuff? By biopsy of the tumor. But there is extensive chromosomal heterogeneity throughout the tumor. That means if you take a biopsy of one point, you might find a lot of monosomy 3, a lot of missing number 3 chromosomes. You might look at another part of the tumor and find, oh, the number 3 chromosomes are both there. And there tends to be a lot of overlap and change within the tumor itself. Yes, ma'am?
You mentioned the BAP1, or you don't mention the BAP1 gene, but it is mentioned
I did
there.
mention the, okay. Yeah, the BAP1 gene is that one which is felt to have a tumor suppressor effect. And in a case of monosomy 3, where you're missing one of the chromosomes, you're missing both of the BAP1 genes.
Are these all genetic or mutation possibilities? In other words,
What do you mean? Mutation.
In other words, these are mutations. You're not born with this.
No.
Okay.
Mutation in the tumor. And there was a question in the back.
Does any of this affect once you get this? It doesn't matter anymore.
Okay, the question was, does any of this affect once you get metastases? And the answer would probably be this is more relevant for the likelihood of getting metastases. Do we know if patient, and I'm going to share the opportunity for answer to this question, but I think we don't know that once a patient has METs, have we ever proven that one genetic abnormality is better or worse than another?
And follow up on that.
I'd like to share the answer. I'd like to get a shared answer to that question.
Can you clarify it? You're asking the difference between primary metastasis?
Well, once it goes to the liver, does it make a difference? And what's more important is, does it make a difference on the treatment? Because if it doesn't, then the first is irrelevant, and is why.
This study has been done using a primary uveal melanoma. So therefore, we don't have a lot of information about metastasis.
Okay.
Yeah. So, but again, the fact that this interactivation, we see the consistent of monotonicity. In other words, if you lose it, you cannot regain it. In other words, if you have BAPA mutation, probably that is there. That's my assumption. So whether we can attack on that, answer is no. Because BAPA mutation is just make all kind of gene activated. So like not only one gene, is being attacked. Another BAPA mutation is like a release of brake. And then therefore many kind of genes going to be activated or inactivated. So that make a cancer is more aggressive in general. However, whether we can attack on a BAP1 mutation, this is an inactivating mutation. So in other words, unless you reinstall BAP1, it's not going to work. So to reinstall BAP1 or reinstall any gene into the human cells is a nightmare. You understand? Yeah. So, and then also there's some medication. Probably somebody going to ask some histone deacetyl inhibitor. So that kind of medicine is going to be, how can I say, make this influence of this gene a little bit less. But this HDAC inhibitor is not going to attack on this specific molecule. Just a general, how can I say, rearrangement of the beta behavior is a HDAC inhibitor role. But it's not going to attack on this specific gene. Okay. I'm sorry, it's getting a little bit difficult. I hope tomorrow we have all days of talk. So some of the speakers are going to rephrase it, so you can have a chance to ask it again. But I'm trying to give you a general idea today. Yeah. Then I'm not a molecular biologist. I'm an immunologist, so somewhat I might be really not perfect person. And somebody.
Yes, sir.
You'd indicated that parts of the tumor could be monosomy and parts disomy.
Mm-hmm.
Fine needle aspiration biopsy. Is there enough tissue taken to actually give you an accurate reading, or is it possible to get false positives or false negatives?
The question is, absolutely, yeah. Okay, the question is, if you do a fine, I used to speak English. If you do fine needle aspiration of the primary tumor, do you get enough specimen to get an accurate answer? My understanding of that question, and please understand, I'm not an ophthalmologist, and I think there are some I think there's an ophthalmologist here tomorrow, if I'm not mistaken, is that they look at the sort of preponderance of the evidence, and they gauge if more is monosomy 3, then disomy 3, then it's monosomy 3, or there are certain cutoff criteria. I can't answer the question any further than that.
What if there's an enucleation and then they have the whole tumor, sliced up, and can you make a determination of does monosomy 3?
I would presume the answer to that is yes. I will comment that I saw that there is a pathologist registered as an attendee for this conference.
We'll
see if you get an answer from her tomorrow.
If you are told that you have monosomy 3 or class 2, that is going to be a dominant factor.
Yes.
In other words, eventually, bad guy is going to kill the good guy. So therefore, the issue is if you have monosomy 3, especially total loss of chromosome 3, we call it monosomy 3. Probably somebody may ask, what's a partial deletion? That is a very problematic situation. We don't know yet. But most likely, total chromosome 3 loss, one of allele of chromosome 3 is most important. Partial, probably close to disomy. That is my impression. And then if you are told that disomy 3 or class 1, there is some sampling error issue. So therefore, still we are going to do the similar follow-up. In other words, we're not going to dismiss the patient, so we just do the same. But in general, if you are told that you have disomy 3 in the tumor or class 1 in the tumor, your prognosis in general is good, in general. And then monosomy 3 itself is just only 70% predictive factor. 30% patient with monosomy 3 doesn't have anything. So in other words, there's maybe additional like AQ amplification. Monosomy 3 itself is not the everything. Okay? And then on the other hand, class 1, class 2, they say 100% vs 30%, like 70%. And then they confirm with using several enucleated tumor, and then there is zero sampling error. But it's a big tumor, so therefore still we have to think that might be sampling error in the contamination of the normal cell. And then depending on the facility, they may say this could be intermix of the monosomy 3 or disomy 3. But if you totally say disomy 3 or class 1, you should be happy about that, but at the same time, probably better to continue the similar type of follow-up as decided based on size or other factor. But in general, sampling error is relatively small, especially tumor is big enough. Okay.
Thank you very much.
Takami was just mentioning the concept of class 1, class 2. Okay, there's a guy named Bill Harbour who's an ophthalmologist at Washington University in St. Louis. He has done tremendous work on the genetics of this specific disease. You're going to hear a talk on this tomorrow, okay? And briefly, to my level of understanding is, from the specimen, they look at 15 different genes. I don't know why they picked those 15 or that sort of thing. Okay, that's beyond me. But by the expression profile of these different genes, if they fit in, pretty much all the patients fit into either one or the other group. And class 1 has a very low risk of metastasis. This is percent free of metastasis. So high number, top of the chart, no metastasis. Whereas class 2 patients have a very high risk of metastasis. As I say, there will be more discussion of this tomorrow. But this is an area of further investigation of interest regarding this disease.
One more question.
Sure.
But there's enough, there's enough number of cases to statistically support the class 1, class 2.
To the best of my understanding, yes. For example, that graph I just had was 172 patients, which with this very rare disease is a significant number. And it's to the point of there's a company set up which does the analysis, and there's a representative of that company here tomorrow. Is my understanding, if I'm not mistaken. I think I saw his name on the list. Unlike skin melanoma, there's no effective systemic chemotherapy, meaning the kind of chemotherapy that your friends or family members have gotten for breast cancer or colon cancer or something like that. There are systemic chemotherapy regimens for skin melanoma, but not for eye melanoma, that have been shown to be effective. And also, there's no proven adjuvant therapy, meaning, what if you fall into that high-risk group? What can I do right now to try to prevent my chance of getting metastasis? Nothing is proven for that. There are some studies going on, basically identifying high-risk patients, giving them something, and seeing if it helps delay metastases. But nothing yet to the best of my knowledge. Because the clinical course of most patients with MUM is based on the status of the disease in the liver, that's why we focus on loco-regional therapy to try to control the metastases in the liver, since there's no systemic therapy. Well, what about surgery and ablation? Because tumors in the liver are often treated by cut it out, or put a needle in it and freeze it, or burn it. Well, they're rarely useful due to most of the time there are multiple tumors in the liver at presentation, and Takami has shown that patients who undergo surgery within 5 years of the diagnosis of patients who develop metastasis to the liver within 5 years of the primary tumor and then undergo surgery for, if reasonable for those 1 or 2 metastases, that there's a very high risk of recurrence soon. So in other words, you don't want to undergo a really big operation to the liver if it's not for some long-term benefit. Yes?
Reoccurrence in the liver or reoccurrence
in the liver.
In the body?
Recurrence in the liver. This is a patient who thought only had 1 tumor and was going for resection, but at operation they could see a bunch of little black dots studded with the liver and the patient. But the problem is those are just the ones on the surface that you want to scoop out. These are liver-directed therapies, which we'll be discussing. So at this point, we're happy to open it up for more questions for the next. Sorry, my less than 10-minute introduction took 40 minutes. But basically, we're welcome to entertain 56 minutes of questions. And if there's interest, I have images that I can show just examples of different treatments. I'm happy to do that. But why don't we start with some questions? And gentleman in the blue sweater, please. And I'll repeat the question.
I've not found any statistical evidence of what the various treatments resulted in terms of longevity or survival. Is there any, or are there any that you can refer to?
The question is statistical evidence that this stuff works. Okay? And to clarify, are you looking for potential benefit of any one therapy, or are you looking at A versus B versus C versus D?
Preferably, I understand that the character of the illness has to be attacked by various means of attack. And so therefore, there probably isn't any one statistic, but is there anything in general? I have not been able to find anything in all the stuff that I've been reading of an average survival rate. And the reason I'm asking this is, we'll come back to this more, I'm sure, is I'm interested in knowing the difference between the survival rate relative to the imposition and your life quality when you get into all this stuff. Which is the essence of my question.
Not a question with an easy answer, but again, the clarification of the point was, how well does this stuff work as opposed to, I think, doing nothing, or, okay, so that's a long answer. One of the reasons why it's difficult to look in the literature for the specific answers is to, one, this is a very rare disease. Two, therefore, series from any one institution tend to be small. Number three, oftentimes reports, descriptions of, we did something, this is how it worked, may not be specific enough in describing the patients well enough so you can compare A versus B versus C. To focus on that answer for a moment. How many of the patients undergoing the treatment started off with more than half of their liver filled with tumor? How many of the patients in this group undergoing therapy had less than 20% of their liver replaced with tumor? How many of them had disease elsewhere in the body at the time? How many of them had no disease elsewhere in the body at the time? So, to get the kind of global comparison you want, it's hard to compare. You can't get apples to apples to apples to apples because there are too many orange and peaches and grapefruit thrown in to get a good answer. Now, to try to offer some answer for that. And
can you go over those treatments?
Yes.
Real quick.
Yes. I wanted to see where the questions would go first, but, and by the way, I mean, I have oodles of slides, but again, as Grant and I discussed, the purpose of this is, I mean, Takami and I came down here today just to be available to answer questions, and so I'll get to yours in one moment, sir. You know what? May I offer? I'm still working on the gentleman in the blue sweater. Okay. Yes. Okay. This is really busy. The numbers are small, and I'll figure out somehow that Grant can get you a copy of this. Okay. But this is published in AJR by Carin. Okay. So, no, let me go back one. No, let me stay on this. Okay, so this column identifies the author. This column identifies what treatment they underwent. TACE is chemoembolization, transarterial chemoembolization. Okay, so these are looking at patients who got chemoembolization as the first-line therapy, meaning they showed up with metastases. This is what was done. Here's one in here that's chemoembolization for second-line therapy, meaning they got something, it failed, then they got chemoembolization. Okay, so these are all chemoembolization papers, and there's really only been one significant paper that's come out on chemoembolization for this disease since this table was constructed 2 years ago. Okay, then hepatic arterial infusion of a medicine that's not available in the United States. Then immunoembolization. I'm not forgetting your question, sir. I'll get back to it. And then isolated hepatic perfusion, which we're also going to discuss today. Okay, so for chemoembolization, this is the drug that's given. And then this looks at patients who responded to the therapy. I'll define that in a moment. This looks at, this is survival of patients who responded to the therapy. This is survival of patients who didn't respond to the therapy. And this is overall. And again, these numbers are all medians, except for this one study which chose to publish means. So I'm offering that as a semi-answer to your question, that here at least are some numbers. But look at the number of patients. 30, 44, 20, 14, 24. I mean, these are small groups. And again, most of them aren't stratifying patients by how much tumor they had at the start. This one, which says responders, a 14-month survival for, I'm sorry, the overall survival of the group was 11 months, but then when they went back 7 or 8 years later from the same institution, they got 6 months. So this is a little high. This 21 months is a bit of an outlier. I wouldn't suddenly go presume that mitomycin C is wonderful in these 12 patients, particularly when you don't know the specific characteristics about those patients. So I'm trying to say there's a little bit of knowledge out there about this, and that's something we're trying to answer better. Before I get to your question, I have the gentleman over here to my left. So we'll go through these one by one briefly. Immunoembolization is something that was developed at Jefferson. Again, I'm not trying to make this an ad for Jefferson, but the guy asked me what, okay, as a means of, as patients were having an initial response to chemoembolization, they started developing tumors at other sites in the body. And the concept by Takami, a tumor immunologist, Kevin Sullivan, who was one of my mentors at Jefferson for many years, and Mike Mastrangelo, who's a melanoma doctor at Jefferson who has a national reputation, was could they have some immunologic type of procedure to prolong survival by creating, for lack of better terms, have the body create its own vaccine to try to slow the growth of the tumor. Okay? It is an embolization procedure, and the main effect in the liver is blocking off the blood supply to the tumors while introducing to that environment of the dying tumors immunologic stimulants. Okay? Radioactive microspheres, injecting tiny, tiny beads, much smaller than a grain of sand, that are coated with radiation into the arteries in the liver to try to kill the tumors.
Is that the same thing as surspheres?
That is surspheres. Yep. Okay. Chemoembolization is sort of kind of the same concept as immunoembolization, is the older treatment for this disease of getting a catheter, a little plastic tube, out under X-ray guidance out into the arteries in the liver, and injecting chemotherapy followed by a substance to, or in conjunction with a substance to block off the blood flow to the tumors to try to cause the tumors to die. An additional approach to that, using a newer product, is drug-eluting beads. So imagine, again, the concept of tiny, tiny beads which are permanent in the artery that you marinate in chemotherapy and then inject them into those same arteries going to the liver, and then the chemotherapy leaches off those beads, most of it in a couple hours, but some in a continued degrading fashion. Time release, yeah, that's what I'm looking for. Fashion, again, and the point is, there have been elegant studies there was a very elegant study almost 20 years ago, and let me just go through the concept of it because this is important to this. It looked at if you give, adriamycin is a type of